All right, everybody, welcome to the webinar tonight. I'm Anderson Webb, I'm the co-chair of the SIR RFS Neurointerventional Service Line, and we've got Dr. Pereira with us tonight. So Dr. Pereira is a neurosurgeon specialized in minimally invasive procedures of the intracranial and spinal circulation. He studied medicine at São Luís Maranhão, Brazil. He then went on to do his neurosurgery training at State University in Sao Paulo. And then he did his interventional neuroradiology training in Paris, France at CHU Bicitra and Rothschild Foundation. And he is now working with the Toronto Neurovascular Group at the Toronto Western Hospital and Hospital for the Sick Children. He's one of the pioneers for the treatment of acute stroke. His clinical research has contributed to the development of mechanical thrombectomy as the standard of care, and he led the team that conducted the first in-human robotic-assisted neuroendovascular intervention. Tonight, he's going to be discussing his work related to robotic-assisted neuroendovascular intervention and its potential implications. Thanks for joining us, Dr. Pereira, and taking time out of your busy schedule to do this for us.
Thank you, Anderson. Thanks for the invitation. It's my pleasure to be here sharing my experience with you. As any busy practice, you can imagine that I'm just rushing from my parking lot to the stop. So guys, get used to this life. But it's rewarding. So this is a practice that is growing, and you guys, you have such a privilege to be starting your career now, because you will be certainly doing everything different than we do today, as we do today, things completely different than we did when I started my fellowship in 2005, 6, and 7 in Paris, in the early stages of endovascular. And through all my career, I always looked for outcomes, and I always looked for the possibility of expanding care. And this is actually the genesis of my interest for robotics. And I've been involved in chasing opportunities to be involved for years, until I had a good collaboration and connection with Corindus, that now part of the Siemens Healthineers, that I think for us as a field is a great opportunity, because we have now one of the biggest imaging companies supporting this development in your field. So guys, take this and develop, because we are now starting the first steps, but what will be the future? It will depend on the continuation of this work, and you guys will take the lead from that. So the topic tonight will be, I will share with you the experience that we have already now with robotic endovascular surgery, which is a field that is recent. So I've been following up some of my early patients that I did 15, 16 months ago. And it's been a very rewarding road up to now. And I have to thank my team. So now I'm currently working at the University of Toronto, Toronto Western Hospital. In a couple of months, I will move to another practice in Toronto at the university too, the St. Michael's Hospital, but I will continue working with this this field and expanding to all the remote possibilities that we can imagine. And if we think about robotics, what is robotics? You know, we see the Da Vinci, which is the greatest robot on the surgical side that we know up to date. But robots mean programmable, actuation, and interaction. And you will hear about nanorobots, robots that are injectable to deliver medications. Sometimes it doesn't necessarily mean a mechanical a machine that will actually do surgery for us or with us or controlled by us necessarily. Keep that concept, because for the future, you will hear about all these robots that actually it's not what we think about the robots that we see in the movies, for example. And the robots are now present in many industries. I think the medicine is the latest field that robots are present. If you see the car industry, completely revolutionized and now operated a lot by robots, and they are more precise, they can work 24 hours, and they increase the safety and the quality of the production. And to what some people's concern, it didn't necessarily change the number of people that have to operate those machines. You need now an engineer to operate every one of these robots to keep the quality and to keep the operation. So actually you have in these factories the same amount of people working, but now they are more qualified, they earn better, and they are not just the people that used to screw one to to rotate one screw at a time over a line of production. So I see robotics as a great development for industry overall, bringing up the operators to a different level, and this is what medicine will become. And if we see, these are like humanoid robots. So the initial steps, this is a movie in 2008, and this is a movie, the second movie that you will see is a movie from a robot that you can actually buy. It costs around $400,000 or 312 now with the current crisis, and $312,000. And this is a robot that you can use and you can program to execute functions in your house. It can serve as a waiter, and you will see how the current robots actually have the possibility. So this is a little bit more than 10 years, and you saw from early steps as your kid giving the first steps, and now you see a robot that can jump and can actually serve a whole party, and a lot of parties have been actually served with these robots. That is actually something that is very good, and this is the level of the robots in other areas. When you speak about medicine, robotics is in different fields. We have the pharma, nursery, some hospitals are completely operated by robot on transportation of dangerous materials. You have telecompanion, telepresence, all the support on people in the home care is done by robots. The exoskeleton and the rehabilitation, they are now a lot of it automated, and people that can walk with the help of robots. But our focus tonight will be on the surgical robots. And the first surgical robot actually was called Afro Robot, and was actually developed to support orthopedic surgeries, not to be the surgeon, but to be the assistant of the surgeon and the scrub nurse to get the right material and actually to make the movements of the joints when the surgeon was going to operate a knee or a hip. And this is 1983. If you think that the first, probably in the 80s, the whole car industry had already switched to robots, we were doing our baby steps. So today we have different systems, and we have particularly the Da Vinci robot that revolutionized abdominal, pelvic, thoracic surgery, and still looking for its ways in other fields. And there's probably now almost 70,000 physicians trained and training and operating a Da Vinci robot every day. And the potential of these tools is to increase the precision, to improve the clinical outcomes, to decrease the surgical morbidity, but also in the future to perform remote care and open or create the care of a surgery, or develop a procedure in an area that actually is not available. due to distances, different healthcare systems. And this is the potential of robotics, because if you can remotely control, you open such a field that we cannot even imagine working in our future. We'll come back at the end of this talk about it. When you speak about endovascular robotics, we have to think about two kinds of systems. One system is the navigation system, which is actually just to perform diagnostic. And this is just to navigate catheters and inject contrast manually or with a pump. And the robotic systems that are actually the systems that can perform interventions. There are a number of different robotic systems, but the system that actually has been approved, that they approved to do, has been the Corindus, the now Siemens company, to perform angioplasty and peripheral interventions. There is another system called Hansen that had also a navigation system, and there's a system in France called RoboCath that is now approved to do some coronary interventions, and those are the systems that we have available today to perform interventions. To perform neurointervention, we actually have one system that has been adapted to it, which is the Corindus system, that is not cleared in North America, and it's under investigation. So we've been enrolling patients in a clinical study to be able to do this. But there is now a prospective study to actually evaluate this robotic system on the treatment of brain aneurysm. This is what we will be talking about this lecture from now on. And the system consists of a robotic arm that is actually placed on the bedside. If you see this picture, this is what I'm indicating here with my mouse, and we have a closer view of this robotic arm in the inferior left corner. And there's a different component, which is the console control, that is composed by a power, like a high definition screen that actually reproduces what you have on the bedside, and a control of the robotic arm that you can be inside the room. Then you have this cockpit, which is LED shielded, or you can be outside in a different room, controlling the procedure and having actually the connection with any remote system with your team inside the room, and actually you will be operating the procedure completely remotely and based on your screens. This requires a lot of training, a lot of work on the workflow, because as a surgeon, and you guys that have been primary operators, you know that you actually are responsible for the procedure. You are on the bedside of the patient, you actually do everything. When you do everything remote, you have to trust on your bedside team, which sometimes not that it's very difficult if you don't have the bedside team that can execute and control the perfusions and the blood reflux and bubbles the way you usually do. So it requires a certain training, and also requires certain training for us as an operator to actually give this task to someone else in a procedure that you actually are the most responsible physician. So this is a closer view of the robotic arm, and there are two components. One is the fixed one, which is actually the robotic arm, and that is actually a cassette, which is a removable part, which is sterile, and where you move for every procedure. And this cassette actually is the part of the robot that will be sterile, and that you will actually connect the micro catheters and the devices. And in a closer view too, you have a place to put the RFS from your micro catheter, which is what you use to deliver coils, stents, and actually is your tool to deliver the care when you are doing endovascular. an endovascular robotic assisted procedure today, it starts from the guiding catheter. So you have to do the groin puncture manually. You have to navigate your catheters to whatever axis you want to work, carotid arteries or vertebral arteries. And from that point, you put the microcatheter in, and then you connect to the robot system. And from that point, you have the fully robotic assisted procedure. Only at least with this system at the intracranial level and operating the microcatheter, micro guide wires, and devices, coils, and stents particularly. So here's a closer view of the RHV of the microcatheter. This is a line for the wire that has wheels to push and pull, and that also has this rotational drive that actually helps us turn to one side or to the other side. We will talk about this in a few slides. And there's the linear drive that's actually to operate the devices. And through all this development, we've been involved a lot before the first clinical cases in the experimental testing and development. So we tested a number of different access, and we, some catheters are too short, some catheters are too long, some microcatheters are not adaptable. And we had to test different setups. We did it all completely in vitro using patient-specific silicone models. And when we found the right formula, and when we identified the patients that agreed and we consented to be the first cases, we actually made patient-specific models, and we did pre-procedure rehearsals to actually simulate the procedures that we would plan to do. And that brought a lot of learning, not only on the procedure itself. At least for me as an operator, I was used to test many times. It was not a big change doing in the patient that I would do a couple of days later. But the big change was on the workflow. I had to improve and actually communicate better with my bedside team. And that was hard for me to trust my bedside team to do everything as I wanted to do. So that the pre-procedural rehearsal was important for us to set up the language that we would take the control of the procedure on the remote station or on the bedside. And we had to establish actually a good communication and make everybody comfortable. Me particularly being far away from the procedure in operating, make sure that everything was the way I usually do. And then once we had that set up, we started doing the clinical phase. Today, we are close to, we actually did 18 cases already, 6 cases on a first pilot phase, and now 12 cases in a prospective multi-center clinical study, and we are very happy, and this is what we will share from now. This is a setup, one of the setups that we started doing. We were in the same room in a remote location. Now we are set up to work in a separate room, and we have technologists that is trained to operate the robot. So the physician on the bedside can actually be a fellow, can be a colleague, and can be someone that can operate the insertion of catheters and the control of the perfusions, but it doesn't require any special skills. The robotic trained technologist is someone that has to be trained and can operate the robot on the bedside fully, and including in an emergency that we never had, but we trained for it, to actually take the procedure completely from the robot and convert to manual in case of an emergency or an error of the system. It never happens in our never have happened in our experience, but it's something that we trained, and we are always working every new operator that we have on the bedside. And on the operator side, there's a lot of learning to do for sure. All the different skills and all the different automated tools that we have available, it requires a certain, first of all, a manual experience, but it requires also training with the robot. And we will go over that. So those are some of the experimental models that we did. We did different steps. And this is one of the experiments. You see here on the left side, the console, there are 3 joysticks that we actually use to control the microcatheter, microguide wire, and the device. And this is a closer view of the robotic system. And here we have an experiment. We have a model of a paraclinoid aneurysm. And we did a number of different tests. This one, we were actually deploying a flow diverter stent using the robot. And this is a wide neck aneurysm along the curve and the siphon. And here I'm actually operating the robot to deploy carefully and open and expand and use all the maneuvers that we have to do to open the flow diverter device. This is a device called Evolve, was launched in US in August. I don't know if you have the opportunity to see it. It's a very good flow diverter, next generation 64 wire device. But because of the number of wires and the angles of the braid, with the good apposition, it comes also some technicalities that you have to do to actually be able to place properly and oppose the device. So you see here the device distally placed, and we have the ribboning here that is common to see in any flow diverter when you have these tight curves. What we do when we face that, we have to pull back to remove the tension, to make the braids find an optimal angle to open. Then you give the slack back, you push the microcatheter, and then you will see that the stent will just expand and actually will open finally. And then it's a matter of apposition and a matter of finishing the flow diversion. So this first curve is usually the challenge. The rest of the deployment is straightforward. Always thinking that we have to release the tension. These devices, they don't like slack. So on the robot, we can actually control and teach it very step by step and slowly, because actually every movement can be very well controlled. So we did almost 235 experiments. We tested different devices and setup, and this is what we tested everything different. Although for the study today we only do coiling or stent-assisted coiling. We don't do flow diverters, although we did 2 cases that we will show you along this talk. So this is the picture of the first setup, first case done. So we were in the room. Now we can be in the room and outside the room, and this is a closer picture of the robotic system that we have in place. And this is a closer view of the operator console. And as I described, you have this green joystick here. It's actually the joystick that controls the microcatheter. And this microcatheter control can move the device forward and backward, and it does also have some features that we will talk about. In the monitor, you see here, you have all the controls of the distance, how much you navigate, the speed, but it does also give you the possibility to control the deployment of the device. And these buttons means 1 millimeter. It means that you can push the microcatheter only 1 millimeter. This is the control of the guide wire, the same. This is the control of the device. And here on the guide wire, you have rotation. That is actually indicate how much you can rotate the wire, and there are prefix rotation tools that can actually help you a lot during the procedure. So this is the summary of some of these movements. We have rotate and retract, limited speed, millimetric control, and you can move a device faster or slower depending on the movements, and you can also have the device moving faster. It doesn't mean that it will change the safety profile, because you have a safety mechanism that actually control the tension of the device during the navigation or any guide wire. That is actually very sensitive, and when you have some resistance, it actually alarms and blocks you to move anything inside the patient. So we'll give you an example of some of these tools. This is actually an example of rotate and retract. This is a PCOM patient that we have treated. We knew that was a wide neck. The plan was to put a stent at the end, and now the microcatheter was going into the aneurysm all the time, and we removed the wire, and with a press on the button, we could twist and change the curve and the direction of the guide wire with this function rotate and retract. And if we as we continue navigating, we were in the ICA, and you see here we are pressing the button and navigating, and sometimes it's hard to find a good angle or not. In this case, we had a curve and we could find the MCA, and we could navigate until that. Once we were there, the next step on the procedure was to use a function that is active device fixation. That is actually a very good function, because you have the robot that will pin the wire, so we will not let the wire move. Imagine you use a fellow holding the wire, and when you move back and your staff is pushing the microcatheter forward, if you lose a position, there is some stress. Here is the robot controlling the wire, and just with moving the microcatheter, when this function is activated, you can pin the micro wire and advance the microcatheter. The microcatheter tip is here in the carotid. The tip of the wire is here in the MCA, and you will see here with this function how we can navigate the microcatheter. And you see that. So this is actually the pre-procedure rehearsal of the first case. As I described to you, we tested before, and we have chosen this case or cases like our first series and still today of cases that we actually require the precision of the stent deployment. This case, we had such a big basilar and two small PCAs, and we wanted a stent that would fit well to the basilar, but still be below the bifurcation. And this is the pre-procedure rehearsal, and this is me training and practicing on the procedure before actually doing the first case. And that was very helpful. We published this early last year, and this is actually in the inferior row. You can see the actual patient, and she's doing very well, and she's now have the aneurysm completely occluded. It's a sidewall, large neck aneurysm, and this is the team. Good thanks to JM, John Michael, Katie, two big supports from the company, and Dr. Quilter that has actually pioneered the thought and has been leading this field and was the person that introduced me to all this field. This is the 6-month follow-up. We have already a year now, and we actually see that the aneurysm is completely occluded to demonstrate, despite the skepticism of some colleagues, that actually you can do better if you know the concepts and if you do the procedure manually with the robot, because you can add a precision and a controllability that sometimes we don't have with manual procedures. So again, set up, and now let me go through a procedure. This is another patient that had a PCOM, a basilar tip aneurysm, and we have here the guiding catheter in the V4 segment, and we will start navigating the microcatheter and the guide wire. You see here the joysticks. I'm operating the microcatheter and the guide wire. So this is the guide wire. and I'm here moving. Now I actually pin the micro wire and I will advance the micro catheter all the way up to P2. This procedure we had planned to deploy the stent and then do a stent assisted coil. You can see it's a wide neck basilar aneurysm. This has been our practice for years, and we've been very successful with it. So the microcatheter tip is here at the neck of the aneurysm. Then we are navigating back the wire, and we will go with the wire into P1. And then once we have the wire in place, I actually started navigating my microcatheter, and I placed the microcatheter distal. Just move forward here, P1, P2 transition for the sake of time. So now you can see here Nicole Cancelleri, our robotic technologist, specialized, and that you need someone like that to actually operate and being able to support the physicians that are on the bedside. And this is the microcatheter RHV, and this is the cassette. And you see here that everything else is protected. And we are here loading now actually the stent. We see Dr. Kartik Bhatia from Australia that is now working in Sydney, that was at that time assisting us during the procedure. So once you load the device, then you connect to the robotic system, you close the cassette, and then the operator take over. So actually now I started actually controlling the system again, and actually I started doing so you have those beeps that actually every time you move, it gives you a sound to help you to control. You can make it louder, you can shut it down. I like to hear the sound because it's a good also warning that the device is moving if you actually don't see it moving on the screen, because sometimes you have a slack and you don't know if the device is moving or not, but actually sometimes it's moving, but it's actually increasing the slack during the system. So I had here my stent navigated into P1, and I will move forward a little bit. So I like to deploy the stents with a millimetric control. I actually using 1 millimeter forward and backward in the microcatheter and the stent. This is the stent deployed, distal markers, proximal marker, and then subsequently I navigated my microcatheter towards the neck of the aneurysm, and I was ready actually to change to a wire to catheterize the aneurysm. So this is the aneurysm catheterization. You see that the wire came towards the PCA. I didn't want, I wanted to turn to the aneurysm, and you can use those functions of rotate and retract. Now you see my wire directed to the aneurysm, and that's how we perform the catheterization of this device. So once I was in place, then the next step was to catheterize the aneurysm with the microcatheter. You keep the wire in place and then you navigate. So I like to do it millimetrically. You see that it had a stent, there was a jump, but you can control that slack on the system very well. I repositioned to the position that I wanted, remove the wire, and then the following step was to change the wire and then start actually putting the first coils. This is the first coil. You can switch from a slower placement or longer, and this is a step that, you know, sometimes depending on how the first coil goes, the first loops are smaller, and then you actually watch how sorry, it's a long time. So you watch how the coiling actually does. So we do this a lot when we are proctoring or when we are teaching our fellows. We actually use a lot of these skills of actually watching what's going on the screen and actually being able to predict what's going on and know if you need to push more coil or if you need to release the slack on the system. And to some people that like actually to have the control, the haptic feedback, to feel what's going on, when you start doing more robotics, I actually realized that we use more of the visual control than we think. And actually, I proctor or I assist more my fellows than I perform procedures, or I perform the complex procedures or complex steps. And the initial steps of the navigation, I actually follow the visual control. And actually the same experience with the robot, except the fact that you actually control yourself. So this is something that we have to keep in mind. And this is something that you have to adapt. If you need that feeling, then you have to go through a longer adaptation and through a longer training period. But if you are used to teach to visual controls, you will be closer to be ready to start doing robotics. And this is actually the placement of the first coil. In this case, we progressively filled. And you don't change the position of the microcatheter. Once the coil is attached, you detach, you remove from the cassette, you put a new one. It's the same time, it's similar to what we would do manually. And you will see here progressively the coiling and the filling of the aneurysm. This particular case, I hope I can go to the end of this session. We actually started coiling just the tip of the aneurysm. And that was very interesting because we actually had the inferior portion of the aneurysm that was not necessarily coiled similarly to what was happening in the tip. So we coiled the best, and what I would do manually is to change my position to the inferior. And what I did with the robot, same. So I coiled distally. I was happy with it. I could pack the aneurysm that at my satisfaction. And inferiorly, I was not happy. The aneurysm was not packed enough. And I tried to place a coil and I tried to move my microcatheter with the coils. I couldn't. And I could manipulate and re-enter the aneurysm multiple times with the robot. And at the end, I took a microcatheter and I repositioned my microcatheter. So that is some of these maneuvers. I removed the coil and I changed the position of my microcatheter. This is the movie of this change. And I'm just showing this. This is the longest case that you will see in this presentation. That because you are using the robot, it doesn't mean that you have to underdo or not do everything you want. You can do everything you want, and you have to do everything you want. But you have to understand that it will be controlled. So I wanted to change the position of my microcatheter. I put the wire again, and I started repositioning my microcatheter to the inferior portion of the aneurysm. And this is what you see here. And I placed more coils, and you see here that is packed nicely. I was happy with the result, and this is the final run. Stent-assisted coiling, 2 repositions of the catheter, and I was happy with the result. This is the follow-up. We have already 1 year, similar aneurysm completely excluded, and this is what we should aim. It's not that because you are using robot that you have to underdo things. It will make you do things better and more precise, and this is the way I am doing, and that I have been doing all these procedures. So up to now, I have to update that. So 18 cases, so 2 flow diverters only, and 16 stent-assisted coiling. The 2 flow diverters we deployed was the Silk Vista Baby and the Surpass Evolve. And now we've been doing the cases in a prospective study that we only are able to do regular stenting with coils or coiling alone. The first phase of the procedure of this study. We had the feasibility phase, and actually we had the proof of concept. And our aim was to demonstrate that we could treat wide neck aneurysms with the robot using stent or coiling, and that the procedure would be done completely robotically without manual conversion. And all the intracranial steps performed robotically. And manual conversion was any step of the procedure that you need to remove the system from the robot and perform it manually. We will also watching, we are still watching for procedural complications and also any issues that we might have with the robotic system. And this is the list of the 6 first cases. Was just accepted for publication, and we actually treated basilar aneurysms, PCOM, paraclinoid, and PCA kind of aneurysm, and we did stent-assisted coiling most of the time, and the procedure times were not changed compared to a regular procedure. And also the radiation dose was similar, and we took in consideration just the robotic part, because sometimes some of these patients would take some time to place the catheter, and that we did not consider for the robotic part. And in the first 6 patients, we didn't have any MRS change as well. We don't have until now. And we deployed 6 stents, and we did coiling in 2 cases that were not related or not done with the robot. And we used Neuroform Atlas, that is still the stent that we use the most, Silk Vista Baby, and Surpass as a flow divergent. And we had, in the first 6 cases, no thromboembolic complication. These are the cases that we did in the feasibility phase. Now we are in a study phase, and we cannot publicly report these cases. They will be all reported together with the full clinical series. And the cassette chains we had to change in the first procedure. The cassette is that removable part, because it was not controlling the wire very well. And in the last case of the series, the same, we had to change. It was actually a problem of the wire. We had to change the wire. We had a wire that had a coating that was like actually slippery in the wheels, and we changed the cassette because we were trying to find out what was the issue on the control of the micro wire. We had no robotic conversion, and we had no failure of the robotic system. This is a case of a patient that came with a ruptured PCOM aneurysm. You see here an injection of the vertebral. This is a tricky anatomical case to understand. And this is the P1, this is the PCOM, this is the carotid, and this is the MCA. Actually, this patient had a chronic carotid occlusion, and she had the MCA and the anterior circulation fed by this PCOM that developed this aneurysm that ruptured. So we did coil during the acute phase. As you can imagine, a large aneurysm like that, we protected the sac, but we left for the subacute phase the neck and the reconstruction of the artery to be performed. And we decided to include this patient in the feasibility phase. We did a radial approach, as we do for posterior fossa lesions, and we came through the vert, and this is my guiding catheter here in the distal vert, and this is my micro catheter. And this is a flow diverter stent called Silk Vista Baby that yet to be approved in US. That is actually navigates through a 17 catheter, and is used for those distal vessels that you actually need to navigate and to place the stent precisely. This is a very good stent to place, and if you know manually how the stent works, it has a very good compatibility with the robotic system. And this is the stent finally deployed. This is the unsubtracted view, and yeah, this case is completely excluded now. We just did an angiogram. I didn't update with the image from yesterday. but the aneurysm is completely excluded that we would expect with this coiling on the sac and a full diverter across the neck. This is the series of the first cases. You saw these 3 cases now. These are the subsequent cases, PCOM, basilar. The last one is the flow diverter that was used with the Surpass Evolve. And then we started going more distal. And this is the first series of ACOMs. And the ACOMs, you have actually to use the robotic system to a large extent. You have this slack on the system, and you will have to use these 2 tools to control the catheter in a more sophisticated way. And you see here a small neck ACOM aneurysm being actually catheterized. That sometimes can be tricky with the robot, and then having the microcatheter navigating. This is a large neck ACOM, and this is the model that we practice crossing the ACOM and deploying the stent from A1 on the contralateral side. And this is actually, these are images from the clinical case. And what I liked in this case is actually the procedure, the ACOM didn't exist. It was A1, A2, then the aneurysm, and then the A1, A2 on the other side. And you see here how we can control. I was doing completely robotically, and how you can navigate the wire distally, and how you can actually perform the navigation as you would do manually. But you see how controlled is the procedure, and I was actually very impressed with the performance of the robot with this case. This is the final control. Not only the lobe of the aneurysm, there was an inferior lobe that would be very tricky to coil, and this is what we did, and this is the result that we had at the end. And if you think that is difficult to operate, these are my kids. Some of these experiments, I had these guys that I had to take care of, and they were playing in the angel room. And this is my son actually. Backward, backward, faster, backward, faster. Okay, now forward, faster. Now forward, slow. Very slow. Yeah. These controls are very intuitive. Backward, honestly, faster. You don't need much training, but you need to be trained in manual procedures to understand what it will do, because the robot is very controllable and it's very sensitive, and I think it's very safe too. Now we go to the next step. You saw what we can do today with aneurysm coiling, and the next step comes to a bigger problem, which are the strokes. Since the randomized controlled trials published in 2015 that brought thrombectomy to level 1 of evidence-based medicine, and also with a very low number to treat patients, the number of strokes increased, and every hospital and every system is concerned and exploring ways to expand the access to thrombectomy. But there's a problem of stroke, that is time. And there's a problem also, particularly in countries like US and here in Canada, there are distances. This is a paper published by Dr. Siraj, and he actually calculated or studied the access to EVT centers across the United States. And you can see here the distribution. It's actually very low. Canada is even worse, because we have the population concentrated in the south part, and you have very densely populated areas isolated, and patients that sometimes take hours. In hours, I mean 8, 9, 10 hours to get to a center to perform thrombectomy, completely unfeasible in a context of an acute stroke. So those cases, in this perspective of stroke in countries like US and Canada, motivates and think about that now, if we can operate a robot in a room just beside the procedure, can we do it distant from a longer distance and improve the access to procedures. So the cardiac world is already far ahead. There has been a number of remote procedures. This is actually a series of cardiac progressively remote procedures from intrafacility with different controlled mechanism from a different hospital or a different hospital complex. And last year in India, a colleague did 5 cardiac procedures, stent angioplasty, 20 miles away. There was recently a procedure also performed in Europe with a cardiac procedure with the same distance. And all these systems, unfortunately, they can only operate microcatheters. But the idea and the concept is there. This is what we have to foresee from now, is that we need systems that we can actually be able to perform robotic procedures in the future. So this is the publication that he could perform everything he wanted, but we have to agree that the cardiac navigation is completely different than the neuronavigation. And sometimes on a stroke, the biggest part or the most complex part is actually to get to the supra-aortic vessel that you want to assess. I haven't done a stroke because the system is not set up yet and we don't have a study for it, but this is an experiment that we actually did. This is a model simulating an MCA occlusion. And actually, if we can navigate a balloon guiding catheter, we can do a mechanical thrombectomy with a stent retriever like the old times. So this is, I navigated, actually my son navigated this microcatheter, my daughter removed the wire, my other daughter navigated this stent retriever, and I'm now deploying. And this is the deployment of a stent retriever with a simulated clot. And on your right, you can see here, I'm actually pulling. This is an embotrap with the coil that is actually being pulled like the old times with the balloon guiding catheter inflated without distal access catheter that you cannot adapt to the system to perform the intracranial portion robotically. But this was a very successful attempt. But you need someone to actually place the distal access catheter or the balloon guiding catheter into the vessel. So a proof of concept we can do, and now just a matter of establishing the systems and the connections to be able to operate safely a robot from a longer distance. And this is what is next. This is a slide from Corindus and Siemens that is showing actually what is coming next: automation, remote capabilities, a lot of safety alarms and mechanisms to help you perform the procedure not only in your site but also remotely. And I think today we can say that remote robotics bring to endovascular precision, particularly on stent and devices deployment. It requires the knowledge of the devices manually, and it has to be studied. And there is a study now called CorePath DRX Neuro Study, multi-center, Europe, Australia, and here in Canada. And actually, we are evaluating this technique in multiple sites to actually study the impact of the robots in the endovascular treatment of aneurysm. And the road to remote neurovascular procedures is open. Automation and procedure safety features is actually what will help us to enhance and to develop even more this technique. So it's coming to an end. I thank to my team and the team from Siemens and Corindus for the support. And I thank you for your attention, and I'm looking forward to your questions. Thank you very much.
Great presentation, Dr. Pereira. That was fascinating stuff, and we all thank you for your work. It's really advancing the field. I did have a question. Just what do you see as the next milestone for this technology's improvement? What's the next hurdle to overcome?
It's the establishment of remote and actually adding another axis to the system. So now we can only do we can do the intracranial portion, but we can't navigate the access system. This will be one step, and the second step will certainly establish remote, because different from other surgical robots, some techniques are still yet to demonstrate the benefit. On stroke, we have the time against us, and if you can perform a procedure and save a transportation time of even 2 hours, it's yet to be determined, but that will be enough. That will be huge. And I think I have no concern that a robotic system, the way it's being evolved, will be able to perform this procedure in the future. But those are the steps that we have to overcome, being able to navigate the access and perform the intracranial procedure with the same system. So you don't need a complex setup in the remote location, and being able to control safely and develop the remote capabilities, not only for remote control, but also for communication. I've been working doing a lot of teleproctoring, and this requires a different skill and a different setup. And there's a number of systems that is being developed. And if we can say that COVID times brought any positivity, it brought the connectivity and brought these tools, or helped improve these tools, because today you can actually guide a procedure in a distance with actually a good visualization and a good control and a good communication with the operator, as you would be on the bedside. And for new technologies, education, training, support, this is huge. But I see the next step adding it to remote robotic procedures in the future.
I'm fairly early in my training, so this may just be my very fundamental understanding of the procedure. But when you're saying access, you mean just the puncture, or access all the way to the supraortic vessels?
The catheters in the neck, in the supraortic vessels.
And what is it that the robots, what technological advances does the robot need to make that possible?
Yeah, now all those wheels, they have to be to hold the catheters very well. So although from 14 to 35 guide wire, there is a small visual difference, but from a mechanical perspective, it's almost double, triple in size. And you need wheels that will be adapted, or different headsets of robots that can control the procedure differently. And if you think that during the procedure you have to adjust the access and you have to adjust the microcatheter, and I'm simulating here the movements that sometimes we do, and if you want to do everything remote, I have to be able to control here microcatheter and microwire, and I have to be able to control my guiding catheter and my catheter here. So you have you need to, if you want to do it systematically, it's not doing one case and you cannot reproduce to 80-90% of your cases, that it wouldn't count. What would count is a system that you can do 80% of your cases, but then it needs to control the guiding catheters, the wires to navigate, and the microcatheters and the microwires and the devices that you have to use during the procedure. And then you don't need someone that is extremely experienced on the bedside to do everything for you. And then, you actually don't need much do remotely if you have someone that can do most of the steps of the procedure. So I think to be able to expand the access, we have to move to this direction of being able to do different steps of the procedure fully robotically.
Have you seen some progress on that forefront yet, or just in the early phases of that?
There's a lot of progress, and I think the communication will be key, the types of controls, and also once this will all be in place, you need to work on ethics. Who will be responsible for the procedure remote? Who will be the most responsible physician? If there's a problem, how you will consent? you will have to work all these things in parallel. But I think this is the future. The benefit is huge, and all these things will be small stones that we have to overcome, or small barriers that we have to overcome, but also for our understanding. If you have someone that is 7 hours away from a center and then you have to consent to do a remote procedure, you know, and then we have to move towards the randomized trial to demonstrate that benefit, that, hey, I am saving your life. You have no alternative, or you will travel 7 hours, or we can do it here. And if there's a problem, there's a problem. You know, this is the kind of understanding that we have to migrate, instead of being worried, oh, if there's a problem and you are remote. Hey, I'm trying to save a life-threatening disease that has no other alternative. I'm expanding. I'm actually saving 80% of the lives there. Some I will not be able to treat. Some I will not be able to do remotely. And there will be some complications, but as a society, as a method, this will be a revolution. That's the way I think we should see, and that's what we should move forward in, not only in the technical development, but also on us as a field, on the understanding of consenting, ethics, regulation, studies, to demonstrate the benefit and in moving this forward if we have the technology to support.
Absolutely. We have a question from the audience here, if I can. How can you prevent Wi-Fi disruptions with remote procedures?
We don't know the connection. It can be satellite, it can be cable, it can be internet, Wi-Fi. This yet to be determined. This is a very good question. And there was a study done by Corindus connecting west to east coast. And even on the peak times, they did a number of experiments controlling remotely experimental two robots. And even during the peak of the use of internet in the busy hours, in the rush hours online that you have a lot of people using, that the internet declines in activity, the speed that you need was still considered on a safe zone. And what is a safe zone? Is the control, is the reflex from your eye to your hand, which is about 0.2 seconds. So what is the safest delay that you can accept? Is the movement that you can perform and what your eyes can pick, and what your eyes can pick and the movement that you have to perform to actually counteract something that you saw that is dangerous. And this is around 0.2 seconds, can be a little lower for some people, but you can get it, but it has not been tested in a longer procedure. And I think this is still a field that is open. We need to understand the stability of these connections. And I don't know, probably satellite, probably. And we have actually to establish safety mechanisms, and the companies that will do remote will have to move forward, because imagine you, based on these connections, you cannot allow every movement that you will perform to be actually transmitted to the remote side. So there's a number of different aspects to be considered. And this is all an open field. This is actually our research now, this year on, and that we will be doing at the St. Michael's Hospital. And this is what it will be the focus in the future: establish the safest and the best connection to actually do these remote procedures in the future.
Absolutely. So one more question. What advice would you offer to a radiology resident early in their career who's interested in neuro-IR, specifically interested in receiving training in this new technology and being an early adopter and helping advance this field?
I think first of all, the fact that we have robots now, it doesn't need to change your mindset that you need to understand the disease, the anatomy, that you need to understand the indications, and that you need to perform the procedure manually. Because imagine that you have an error and then you can only perform the procedure robotically, it'll be bad for you. So, and the robot, there's no automation now. You need to know the procedures manually. So I think it doesn't change your initial training, but you can adapt. And I'm sure in the next 2 to 5 years, a lot of centers will have the robot. We will have a training program in the next couple of months that will be open initially for experienced users, but then we will have a discovery program for residents to actually explore this technology and get used to it. I think initially I would encourage to explore, to do research, and if you have access to experiments, more experience with the different platforms of control, that will be better. But I think to adapt it as a practice, you have to be fellowship trained and be confident with your procedures manually. And then I think this will be a field of the future. But I think it will not change your training steps. And I think you have to get the max of your training with your manual experience as possible.
In this, so you likely need to attain different or additional training after fellowship. Would that be, what model do you imagine for that? Just on-the-job training, a several-month course, a full-year fellowship? Have you thought about that yet, as to how people might be able to?
I think if you are fully trained on manual, I would say you need a discovery training that will actually make you familiar with some procedures, and then a more advanced training that will actually bring you up to speed with different setups. So setting up a vertebral aneurysm, a PCOM, and an ACOM is completely different. I did the other day pericallosal, completely different setup. So this is a more advanced training. So I would see a stepwise, a 3 training step with some experience on the basic, some experience of intermediate cases, and some experience with a more advanced cases. This is what we want to set up initially for experienced physicians, but then I see in the future the migration towards robotic practice with that. I don't see navigate a microcatheter with the robot. That's stupid. You can do it with a model. You don't need to be practicing navigation. I don't see that. I see procedures, and I think all these discovery steps you can do it with the models. Patient-specific models are very sensitive. They are very reproducible. But once you are done and you feel confident, you have to go to straightforward setups and procedure setup. I mean access with non-complicated access. Then you go to an intermediate stent-assisted coiling that requires more precision. And then the third step, I would see those more distal locations. And I'm speaking on the aneurysm side. On the stroke, it will be probably the same steps: access, straightforward techniques, aspiration or stent retriever, and then a more complex tandem, stents, plus balloon, plus thrombectomy. So I would see all 3 stages of practice that you will have to train and migrate and slowly adapt the robot through your practice.
Great. Well, thank you so much for your time, Dr. Pereira. Is there anything else you'd like to add in closing?
Oh, thank you for the invitation. I think this is a fascinating topic, and in a practice. Yesterday I did 2 robotic cases, and it's my fellows helped me most of the time. So we did together the procedures. It's an exciting time, and I think in 10 years you guys will practicing and will have this all the time in your setup. Don't be anxious. Don't try to adapt. The steps will be the same until a certain point, but beyond that, whatever we have to do to develop or to adapt a new technology, you guys will have just to adapt to the robot or manually a bit, and then it will be certainly easier as it is now for us than it was 10 years ago.
All right. Well, thank you so much.
Be prepared to keep the ball rolling towards the future.
That's right. Well, thank you for your time, and we look forward to seeing what more work you and your group are able to do. It's really exciting stuff. Thanks for
Excellent.
sharing.
Thank you, Anderson. Thank you, guys. All the best. Bye-bye.
Take care.
You too.